SAPPHIRE 2 really shows us it is an option for populations. It is effective without interferon. It's very similar to other breakthroughs. So let's move on to the PEARL 2 study. Now we're looking, to isolate, identify, and evaluate the contribution of ribavirin. Ribavirin still seems like a last-generation addition to modern HCV meds. So while we're moving away from pegylated interferon, we're also looking to move away from ribavirin where possible. There's a lot of evidence showing that ribavirin is related to skin-related adverse events, like we've said, and it's otherwise considered something that we can do without very often. So that's where the paradigm shift is occurring in HCV medication. So this study starts upon the principles of the SAPPHIRE trials, which again suggested that GT1A and GT1B patients may have responses and results to the addition of ribavirin. So we're seeing if both genotypes, GT1A and GT1B, still need ribavirin. So again, we're looking at the baseline here. We're looking at GT1B only in this case, non-cirrhotic. We're looking at treatment experienced with pegylated interferon populations who previously failed that treatment. So a rather difficult group. Pretty basic design here. One arm gets 3D with ribavirin and another arm gets 3D without ribavirin. Again, the hunch behind this trial is that ribavirin might be needed for 1A but not for 1B. And here we see some of the merits behind that hypothesis. The PEARL 2 study really made the statement about ribavirin and genotype. In these results, we see that SVR actually went down among patients who had ribavirin, while patients who had ribavirin removed from their regimen had outstanding results. Recall again that all of these patients are GT1B. So the conclusion here is that GT1B patients do not need ribavirin in their regimen, and that's true whether they're treatment experienced or not, as well as whether they were a partial or null responder in the past. These are extremely exciting results, and people who are treatment experienced become more difficult to treat generally. Now here we have PEARL 3. We're starting to get the sense here that 3D is having issues with ribavirin and how to incorporate it, or even if incorporated into the regimen. This is important because most meds available can be ribavirin, and ribavirin has had a historically important place in the development of treatment. But as we keep saying, ribavirin can be associated with rashes and skin issues, and some patients have found ribavirin to be problematic and would prefer to stay. In PEARL 3, we're looking at GT1Bs again, but this time they're treatment naive, just to eliminate or evaluate the variable of treatment experience in efficacy. So again, we're looking at 3D plus ribavirin versus 3D plus a placebo. Because we've already determined that GT1B patients do not need ribavirin, PEARL 3 wants to know if GT1B treatment naive patients can also get away without ribavirin. So the guiding question here is, do GT1B patients really need ribavirin at all, regardless of treatment history or response? So there's not a significant impact either way by adding ribavirin. We're talking 0.5% increase in efficacy over, over the two arms. It's also worth noting that in all of these trials we're looking at today, any virologic failures are relapses, or relapses are almost always associated with a resistant variant. So our conclusion here is that the addition of ribavirin does not provide significant additional clinical benefit to GT1B patients, and that stands true regardless of treatment history or lack thereof. There were some transient blood effects, specifically some hemoglobin decreases, but these were infrequent and transient. In fact, those decreases were more common in the ribavirin arm. So let's look then at PEARL 4. We've closed the book on GT1Bs and ribavirin. They don't necessarily need it. So PEARL 4 is looking at GT1A patients and trying to see if ribavirin can be removed from their regimen as well. Here we have one arm getting 3D plus ribavirin and another arm getting 3D on its own. Again, the leading question here is GT1B patients don't need ribavirin, So do GT1A patients need it? So we're actually seeing the opposite effect for GT1A patients with respect to ribavirin. GT1B patients don't need it, but for GT1A patients, ribavirin is associated with significant clinical benefits. Again, we're seeing a small number of virologic failures, but each of them is associated with resistance variants. Our summary here is that GT1A patients do benefit from adding ribavirin to the regimen. This allows us to conclude that 3D with ribavirin is an effective and tolerable treatment regimen for GT1A patients. Also, regarding the transient hemoglobin reductions, follow-up reviews concluded that the hemoglobin levels returned to normal approximately 4 weeks, 3 to 4 weeks after treatment. So we're really starting to come up with some hard conclusions about how effective this medication is, how tolerable, how safe, and whom specifically might benefit most from it, and in which regimen. With Turquoise 2, we're now focusing on some of the hardest treatment populations. The baseline is a mix of people who are experienced, some who are treatment naive, many who were prior null responders, some with cirrhosis. Anyone with treatment experience here was previously treated with pegylated interferon. Both genotypes are present, so a real grab bag. The design here is interesting. Each arm gets 3D plus ribavirin, but one arm gets this for 12 weeks, while the other arm has a treatment duration of 24 weeks. This allows us to hone in on the treatment duration or even discuss whether ribavirin can be phased in or out of a regimen. The results here are really interesting, actually. Ultimately, longer treatment duration is associated with higher SVR. Between genotypes, we still see ribavirin is associated with significant increase in efficacy for GT1A patients. At the bottom here, you'll notice that the treatment experienced patient numbers, and I've separated those by genotype just to give a clear picture. GT1Bs are still doing better, and other than prior partial responders, all GT1B treatment experienced patients are 100% after 12 weeks, and after 24 weeks, all GT1B patients are cleared. Now, for the GT1, longer regimens are benefit to treatment. Naive GT1A, that for prior null responders, longer treatment is associated with being more effective. So the summary here is, again, rather positive. We're seeing amazing numbers for populations we consider to be harder to treat. It also looks like we've really narrowed in on who needs this treatment based on genotype and treatment history, but also for how long. It's very important that we get these questions right the first time, the right treatment for the right length. Again, we're seeing such numbers amidst populations with cirrhosis is extremely encouraging. With numbers like this, saving the lives of people with compensated cirrhosis looks like a real possibility. Let's revisit some of the other things we've learned from the trials we've looked at today. As I've said, most patients, in fact about 90% of them, experience some kind of adverse event or side effect from this medication. The good news is that these were almost always considered tolerable and mild. Further, some of these, specifically the itching, the pruritus, and rash, were associated with ribavirin. There's room in the prescription of 3D to revisit and modify the dosage of ribavirin, so that's helpful. But again, when we consider the adverse events associated with past hepatitis C treatments, the tolerability and relative mild level of these side effects is a very positive development. So what large takeaway messages